Buenos días. Vamos a empezar ya este 24º memorial Lino Torre. En primer lugar, quiero agradeceros vuestra presencia y que hayáis decidido acompañarnos en este memorial Lino Torre, un día en el que celebramos pues, el acto académico más importante de nuestro servicio y también un día muy importante para nuestro hospital. Prueba de ello son los 24 años en los que se viene celebrando de forma consecutiva. Y después de, bueno, tuvimos un año que lo tuvimos que hacer de forma virtual y ya lo pudimos recuperar el año pasado. Además, desde hace ya un par de años lo retransmitimos en streaming. Celebramos este memorial en honor del doctor Lino Torre, quien fue jefe del servicio de cirugía de nuestro hospital desde 1966 hasta 1986. Durante esos 20 años, el doctor Lino Torre supo transmitir a sus discípulos y colaboradores no solamente su excelente técnica quirúrgica, sino también su espíritu crítico, su tenacidad, su inagotable capacidad de trabajo y su sentido clínico. Desde el punto de vista de la docencia, impulsó un modelo de formación de residentes puntero en nuestro país y fue uno de los pilares a la hora de poner en marcha la unidad docente de nuestro hospital. Asimismo, dedicó gran parte de su tiempo a la investigación y puso en marcha líneas que hoy todavía persisten. A lo largo de su carrera recibió múltiples premios y reconocimientos y quiero destacar especialmente el premio Virgili concedido por la Societat Catalana de Cirugía en 1993. Este memorial pretende mantener su recuerdo no solamente para los que le conocieron y tuvieron la oportunidad de trabajar con él, sino también para las siguientes generaciones de cirujanos. La estructura del memorial será la misma de los últimos años. Tendremos una conferencia por un ponente invitado, por una cirujana invitada en este año y que presentará a continuación la doctora Marta Pascual, jefa de la sección de cirugía colorectal de nuestro hospital. Y posteriormente haremos entrega de los premios. El premio clásicamente, en este año, 23º Premio Lino Torre, al mejor trabajo de investigación realizado por un equipo de cirujanos en España durante el año anterior, en este caso publicado durante el año 2021. Pero además también ya introdujimos en los últimos años 2 premios más. El premio al mejor residente, que es otorgado por los tutores en función de la evaluación a lo largo del año académico anterior y también en función de los resultados del examen realizado al final, y el Premi Ignasi Poves al mejor docente del servicio de cirugía, de nuestro servicio de cirugía general. El doctor Ignasi Poves se incorporó a nuestro servicio en el año 2006 y en los años posteriores consiguió desarrollar a un nivel técnico difícilmente imaginable, sobre todo entonces, consiguió desarrollar la cirugía hepática y la cirugía pancreática de alta complejidad mediante abordajes mínimamente invasivos. Gracias a su trabajo, posicionó nuestra unidad de cirugía hepática y pancreática en primera línea a nivel internacional. Pero además de una gran habilidad técnica y de una extrema dedicación y cuidado a sus pacientes, queremos destacar y recordar su gran interés por la formación en los residentes y de otros especialistas. Por ese motivo, entregaremos este año el 3er Premio Ignasi Poves al mejor docente del Servicio de Cirugía General y, como en los años anteriores, se concede a partir de la valoración realizada por los propios residentes de nuestro servicio. Y ahora sí, voy a dar la palabra a la doctora Marta Pascual para presentar a nuestra ponente invitada. Muchas gracias.
Muchas gracias. It is a privilege for me to introduce Mrs. Fahrenheit as our invited speaker today at this memorial. I have had the opportunity to know more about her career, and I have to say that after this little research, I have realized that she really is a great role model to follow for any colorectal surgeon such as me. Nicola Fahrenheit completed her surgical training in Bristol. She spent 2005 at the Cleveland Clinic in Ohio, USA, as the prestigious International Fellow in Advanced Colorectal Surgery, And after that, she came back to Cambridge. No? And after that, she came back to Edinburgh and as a consultant colorectal surgeon. There she contributed to Cambridge Colorectal Unit's position as one of the 5 trusts with the lowest death rates for colorectal cancer surgery in the UK. Her clinical interests include all aspects of our colorectal surgery, including colorectal cancer, laparoscopic colorectal surgery, pelvic floor disorders, colonoscopy, inflammatory bowel disease, bowel cancer screening, and anorectal disorders. Ms. Farnhead introduced the transanal endoscopic microsurgery and the extralevator abdominoperineal excision for rectal cancer in her hospital. Ms. Farnhead's doctoral thesis examined the role of genetic predisposition to colorectal cancer in the general population, and she has several publications in different aspects of colorectal surgery, as fertility after surgery for inflammatory bowel disease, the treatment of large bowel obstruction due to cancer with intraluminal stenting or emergency surgery, the functional outcomes for patients following anal cancer. And she is the current chair of the Research and Audit Committee of the Association of Coloproctology of Great Britain and Ireland, and a member of the ACPGBI executive. In 2013, she chaired the Royal College of Surgeons Committee that produced the National Commissioning Guidance for Management of Rectal Bleeding. And she is member of several associations at Medical Defence Union, Royal College of Surgeons, Royal Society of Medicine, British Medical Association. And moreover, Mrs. Farnhead is committed to training the next generation of surgeons. This topic is going to be to the core of her conference. She's an educational supervisor, ran the regional training days for specialty registrars in surgery from 2008 and 2013, and she is an interviewer for national selection of surgical trainees and an examiner of Cambridge University medical examinations. With such a great experience in clinical research and training aspects of surgery, it is impossible not to look forward to this interesting conference. Thank you so much for being here and for accepting our invitation. Thank you.
Good afternoon, everybody. If I may have my first slide, I'd be grateful. Thank you. It's not that presentation. It's one of my surname in it, which is Fernhead. I've been told it's impossible to say in Spanish. Whilst they're finding it, just to say a big thank you to Marta for the introduction and to Michael for the invitation to come to join you in Barcelona. Have I got it right? Good. Been practicing. It's the number 2 on your list. Thank you very much. Dr. Lino Torre, as you've already heard, was born in 1923, the son of a city lawyer. He arrived in Barcelona as a postgraduate in 1940 when he joined the Faculty of Medicine at the University of Barcelona, and he graduated in 1946. He, like many of us, specialized as a surgeon. In 1966, he became the head of your department here at the Hospital del Mar, and he held that position until his retirement. He has, as you've heard, won multiple awards through a long and very illustrious career. His biography states that he was a master of surgeons and an example of the clinical spirit and emotional formation of students at that time. It is my very, very great pleasure to be here with you today to give the 24th memorial lecture in his honor, with his family present and listening as well, and also with the topic that I'm sure he would have proven very well, and that is training the next generation of surgeons. Thank you for the invitation. Well, surgical training starts at medical school. It probably, with some of us, even starts as an aspiration before that. And I'd like to just mention to you that actually many of the subjects we study at med school are more intended for surgery than they are really for medicine. And if we think about our foundations of anatomy, of pathology and physiology, a lot of that is something that we come back to as surgeons and we can build on in later life. It's still, though, is really important to have that foundation. And the reason for that is that even though that there are digital versions and everybody has access to Wikipedia and Alexa, there's no point in saying, Alexa, where is the circle of Willis? Alexa, how many bones are there in the wrist? Alexa, what do you think about the facial nerve? Are there any divisions and are they important to me in my surgery? Because if you don't know that you have to look for it, you will never have that grounding that will allow you to become a greater surgeon. So although we might have stepped away from absolute rote learning, you have to at least know about something in order to be able to build on it. It's also at this stage that medical students really have the opportunity to understand surgery. That time in the anatomy room is absolutely essential, and anybody who comes forward interested in a career in surgery should really be encouraged right from the very beginning. It's almost too late once you've graduated as a doctor. It's something that you really want to be expressing interest in and building on very early in a medical student's career. We, of course, then need to go on to learn about all the clinical aspects of diagnosing and managing surgical conditions, and slowly but surely getting a very broad sense of what is interesting to us and where we might go. Following on from that, you have this long period of apprenticeship. There's quite a lot of watching, some assimilating, some experimenting, and quite a lot of learning. It's undoubtedly the case that the workshops of basic surgical skills, care of the critically ill patient, advanced trauma life support, and simple techniques are taught at this stage and that they're taught very well. From my own recollection, I remember even as a medical student tying hundreds upon thousands of knots on the backs of chairs in my home, and my family being driven absolutely mad by the fact that they always had to cut something off before they could sit down. From that period, you then go on and you're looking for people who will influence you, your career, and your life. And for me, the first person I met as a medical student, a very junior medical student, was Professor Neil Mortensen, who's the current president of the Royal College of Surgeons of Edinburgh. And he remains very close to me and has been a lifelong mentor, helping at those points when you need a little bit of guidance or where to go next. My other great mentor, as you've already heard from having a genetics degree, was the celebrated genetic scientist, Professor Sir Walter Bodmer, whose portrait you see on the right. Walter still writes to me and still talks to me, even though he's in his 90s. His mind is as alive as ever, and he still has insights that he can bring to your career and to your development. I couldn't not mention the late, great Dr. Victor Fazio. He was an amazing person to work with. He was generous in spirit. His judgment was absolutely exceptional, and he was a trainer who really believed in the next generation of surgeons. My time at the Cleveland Clinic in Ohio was very formative, and also alongside Dr. James Church, who remains a friend to this day. They've certainly left me with a legacy of things that I've carried the whole way through my career. You return as a consultant, you build your own team, and you realize that you've now got a whole nother generation to look after. And importantly, those people are influenced by you in turn. You're building your relationships with the team. This is my very first year as a consultant, a party in our garden at the time. But you also begin to realize that these relationships are lifelong, but so is your learning and your training during a surgical career. It is not the pinnacle being appointed as a consultant or attending. It is actually just the start of a lifelong career in learning. And that is important because when we think about how we learn things in surgery, we all understand the concept of a learning curve. We like the idea of narrowing it up, making it go up faster, making it plateau quicker. But we also have to remember that at those stages in the learning curve, there are patients who may have suffered in the process. And so learning curves need to be looked after very carefully to make sure that patients do not suffer in the process of one achieving one's own skills. And at that point, I'd like just to step very slightly aside because I want to think a little bit about what the future of surgery is. And then we can make some decisions about what the future of surgical training is. I've drawn very liberally on the work done by the Royal College of Surgeons of England in collaboration with that of Edinburgh on the future of surgery. And just to give you a brief summary of the sort of things that they've looked at, they were very interested in technologies and what will have the greatest impact in the next 2 decades. Remember, this is not intended for a century. This is really focused around 2 decades. They were very interested in the impact of minimally invasive surgery and of robotic surgery, but also of that minimally invasive surgery becoming more widely available in low and middle income countries. They recognized the importance of imaging and the interplay between virtual reality, augmented reality, and really good imaging, modern technology. The third part of the big plan was big data, the use of artificial intelligence to help interpret and mine that big data, and the increasing use of genomics, leading on to the last one, which is specialized medicine, which is very much about medicine tailored to the individual, treatments decided bespoke to that patient's cancer, to that patient's cardiovascular system, to that patient's risk factors, and that this is a really important part of the future of surgery. What does this all mean for patients? Well, good and bad things. It means that surgery and healthcare will change. Our perceptions and attitudes to risks are changing all the time. If we look just at how important obesity has been as a major feature in all the cancer campaigns of the last couple of years. We also have to realize that probably fewer patients will undergo surgery, or they might undergo less surgery than they would have needed as a result of neoadjuvant type treatments. We don't really anticipate that health will change. By that, it is most unlikely that there's going to be a major extension in longevity or in length of life, and actually that is probably the case because of the multiple chronic diseases which now affect our population. So we're not really expecting that everybody's going to live to 120 or 150 in the next 20 years. And we have to understand that there may be risks. And those risks are going to be related to the fact that you now need somebody so specialized to help guide you through this increasingly complex pathway that you're going to need your surgeon. And your surgeon is going to have lots of skills apart from just being able to operate or to talk to you. They're going to need to understand a lot about the way the world works, as well as a lot about the background in all of this medicine. And if you don't have that experienced surgeon, your guide to take you through the process, you're going to find that patients become disadvantaged, and there we end up perpetuating the inequalities in healthcare, access to healthcare, and the quality of the healthcare that is given. We also envisage that the patient journey will look rather different in the future. No longer will surgeons just be involved in diagnosis and management and then maybe a bit of detection of recurrence. We're now stepping right back to the point of prevention. And prevention isn't just about screening campaigns. It's about healthcare interventions. It's about public health. It's about us getting out there to give the messages about why patients should attend for their screening programs, why they should look at mitigating their risk factors and so on. Obviously, we all prefer to treat early disease because that's much easier and much less likely to cause long-term harm for the patient. So, in order to deliver this, how will delivery change? And there's several key ways that this is going to happen. We've been aware for many years about the importance of centralization of highly specialized procedures in order to get the best possible outcomes for patients. But think of something else. As technology steps in and we're able to return resources, particularly with robotic surgery and augmented reality, to some smaller centres where guidance can be sought from centralised centres, we may find that what we actually do is spread things out a bit rather than bringing them all into one place where there is not necessarily the resource to manage all of those patients. We've seen an increasing trend towards outpatient care and 23-hour stay if we can. The operating theatre of the future is going to look completely different. It's going to be about sustainability. It's going to be about small components which will be able to be moved around. No longer will we have this theatre belongs to vascular, this theatre belongs to colorectal, this theatre belongs to breast, because it will be much easier to move components of surgery around to deliver surgery within the operating theatre. And finally, a word of caution. We have not yet done a good job of enabling and actually checking our innovations. We've had a little bit too much spirit of just giving it a go and not enough of going through a formal process of training, doing things, evaluating new technologies absolutely perfectly outside of the patient before going into the patient. And we've been very poor at collecting data about those patients and pooling that data so we can see early concerns about safety actually coming up sooner rather than it being allowed to perpetuate. And we've seen scandals like we have seen in certainly the mesh area of surgery. So our future surgical team is going to look very different. We're all going to be surgical professionals. There's no way anybody's going to be out of a job. You're still going to be a surgical professional, but you're going to be doing it in a slightly different way. You're going to be part of a multidisciplinary and multi-professional team. And guess what? There are going to have to be changes to training in order to deliver this. I do want to just put a gentle health warning on the next slide, because I know that there are many aspiring surgeons in the room, and I do not want this to put you off. I want it to be something that you think you can get to. I will just take a minute to go through it. But this is how surgical training needs to change. This is what we need to deliver as surgeons in order to deliver this future of surgery. We are looking at being clinical surgeons, at being scientists, at entrepreneurs, educators, innovators, managers. And we have to be able to flex between those different aspects of our delivery of care during a career. So that means we actually end up needing much more in terms of computing knowledge, engineering, molecular biology, data literacy, leadership, team building, communication. And of course, with increased digital healthcare, we need to have a better way of ensuring that we retain the humanity of the doctor-patient relationship in all of this. There's no doubt that new technologies will help, but they're not the be-all and end-all. They're there to assist the process. That's the data analysis, the augmented reality, virtual reality, particularly in terms of training, and looking at patient-specific simulations, and most importantly, making sure we've got good mentors and proctors in place. So I hope that didn't put you off too much. It does look scary, but actually it is possible, and you don't have to be good at everything all the time, because you can learn and acquire skills as you go along. So this is my view of what we need to cover. This is a personal view now rather than that of the Royal College. I'd like to just talk a little bit about key areas and technical skills, non-technical skills, the importance of the multidisciplinary roles and how we're going to achieve that. And I also want to give some thought to how we develop the responsible surgeon of the future. So somebody who's going to make a difference, not just to each patient, but to the population as a whole and to the environment and hopefully to the planet. So thinking about technical skills, obviously this needs to be tailored to the stage of the surgeon. And right at the beginning, the very basic surgical skills, as we've discussed, about knot tying and going on the courses are really important. I personally believe that we should be trying new things that we haven't done previously in an outside patient experience. So that means within simulations, within models, within cadaveric training. I'll come a little bit more to component learning and some thoughts about robotics, but really just to say that I think we've got to focus where we do our training, not just who we do it on, and we've got to be looking at evaluating that training even if it doesn't happen in a patient. There are still ways of evaluating training outside of the patient. So this is our cadaveric laboratory in Cambridge. I think I've lost it. So I'm losing the slide each time, sorry. Thank you. Thank you very much. That was very kind. My colleague, John Morton, who's our head of simulation and cadaveric training. And each of these, there are 12 stations in our laboratory. Each of them is a mini theatre in its own right. The table goes up and down. It has a translucent ledge to it that you can use imaging imposed on the cadaver at the same time. It's got washable buckets on the side, and it's got every bit of laparoscopic and occasionally robotic equipment. It very much is simulating the environment in the theatre. It also can be tailored to what it is that you're trying to learn. Ideally, cadaveric training is for the final years of training. It's for looking at new techniques and evaluating them, and also trialing new devices from industry. So this is component learning. I'm a very strong believer that you can break every operation down into a multitude of small steps. And it is quite possible to train somebody in just a very small part of a procedure without making them go from knife to skin and back again. And in doing this, it really helps if you've thought about what those steps are. You as a surgical trainer, but also the trainee then starts to be able to write out boards like this when they come to look at it. And the minute they can get to a point where they can conceptualize an operation, see what they're going to need to do, and come up with a board which is very similar to what you would have in your mind, you know that that trainee is right at the end of their training and ready to make that next step. But they also need to know when they might need for help. And so the other thing you can do just to finesse this is very occasionally just put a star next to a component of the procedure where you're just going to get the trainee to pause and think whether they might need some additional help for that specific part, just to get them over the hurdle to the next one. Robotic surgery is definitely the future, especially with its potential for the overlay of artificial intelligence and the reduction in human factor errors. Dual consoles are brilliant for training. They help shorten the learning curve, and the safety mechanism of just being able to press stop as a supervisor is very reassuring in terms of patient safety in that environment. There's also feedback. There's feedback from the data you get from the robot in terms of your personal performance. Was there economy of movement, or was there a lot of wasted time? And while the future may evolve, it's very unlikely that artificial intelligence will take over completely. You cannot envisage, even though it's likely to happen, that an anastomosis, a critical point of a procedure in whichever it is, vascular or GI, is done by robots and artificial intelligence. It will come, but it will be overseen by a surgeon. In the same way as you still have a pilot in the cockpit when a plane is flying, because if the computer fails, there has to be a backup. And so there's no way you're going to be out of a job, so it's not something to fear, it's actually something to embrace, but also to be aware of becoming de-skilled and making sure that you keep your ongoing training up, very much like at pilot's hours. In terms of virtual reality, obviously there's a fantastic experience here in terms of out-of-body training, learning procedures and components of procedures. It helps a lot in terms of providing haptic feedback, and the experience will usually be as good as the model, but not every model has to be perfect or very expensive. You can still learn a very basic technique with a very, very simple model. There's no doubt that the remote platforms such as Proximi and React for teaching can provide augmented reality and opportunities too for live remote proctoring or decision-making in complex situations. In terms of non-technical skills, the one I'd like to highlight here most is the human factors. But I also then want to spend a little bit of time talking about shared decision-making, because this is going to be our future as surgeons. So the Swiss cheese model of lining up to make sure that a series of errors results in one accident rather than the safeguarding mechanisms that prevent that accident from happening is an important concept in surgery. About 75% of errors which occur during surgery are due to human factors, not to technical problems. And so it is important to have situational awareness, and we have to teach that situational awareness to our trainees as we go forward. And we should unashamedly borrow from the aviation industry here, who've understood this much better than we have over many years. Even it's down to our electronic prescribing, there are fail-safe mechanisms that can be placed in there. You can look at the psychology of environments under stress. You can look at the organizational factors, which means that the kit you need isn't there. What I'm trying to say is it's very easy for one thing after another just to line up to give you that hopefully not never event, but certainly a dramatic complication. Now let's focus from there onto patient-centered care. And my reason for saying that is the human factors really, really determine how good your patient-centered care is. Because if you've got the patient at the heart of every thought and decision you make, then you are much less likely to have a human error affect that patient. So what is patient-centered care? It is a way of delivering healthcare that views patients as equal partners in planning, developing and monitoring their own care to ensure it meets their needs. It puts patients and the families at the heart of all decisions, treating them as equal partners, working alongside us as clinicians. Now, this is not about just giving the patient what they want. It's completely different from that. It's about considering their desires, values, family circumstances, their social situations and lifestyles, seeing that individual as an individual and helping them to develop a plan around their care. It's about being compassionate, thinking of their point of view, and being respectful. It starts right at the beginning and it goes through to the end, but you can involve a patient in their care from start to finish and do it at a level where you give them the right amount of information at the right time and with the right support. Shared decision-making is slightly different. Shared decision-making is when you really get down to the nitty-gritty of what is going to happen to that patient. It allows them to come together to make a decision about what works best for them. An example in colorectal surgery is after radiotherapy for rectal cancer. If you've had a complete clinical response, you might want to consider watch and wait, rather than having a resection and all the functional consequences that goes with it. But if you're a gambler and that's fine with you, that's great. But if you're a bettor and you just want to be absolutely sure that that cancer's gone, then you might prefer to have a resection and accept the consequences that come with it. And whilst we're thinking about how we evaluate surgery, this is just to give you an idea of how things have sometimes just come in because it seemed like a good idea. And that's not to say that any of these are necessarily dangerous, but it's no longer acceptable just to introduce something new without the proper evaluation. And the ideal collaboration has given us all the research tools to do that, but what we haven't caught up with is all of the administrative and process parts of putting that all together, because a randomized controlled trial may not be the best answer or best way of answering a research question about new innovation. I do think an important part of becoming a surgeon is to have good mentors. When I was president of ACP, this was one of the major initiatives of that year, is to really look at the Early Years Consultant Network, finding and matching mentors. And you don't need to have a mentor for life. You can use a mentor now and then for specific needs of what you're doing. And the trainers in the room, please don't forget the value of inverse mentoring. That is asking your trainees to help you with things. I have been profoundly privileged to have had two very, very good inverse mentors who've been an enormous help to me in my career, particularly when you're trying to do some things that you might not be that comfortable with. The multidisciplinary roles are a little bit more obvious. You've just got to think about what you want, grab the opportunities as they come past, think about taking time out in other clinical specialties, industry attachments. Make sure you go on specialized courses and consider doing fellowships, research fellowships, clinical fellowships, and slowly but surely building your relationships, because all of this is about a network of relationships which will allow you as a trainee to deliver care when you yourself are delivering that care. And finally, a few words about the responsible surgeon. It used to be said that a good surgeon needs an eagle's eye, a lion's heart, and a lady's hand. But the modern surgeon has to act as a patient advocate. They have to have integrity, good communication skills, enthusiasm, a degree of resilience, emotional intelligence, and really sound judgment. That's a lot to ask from anyone, and each of those facets of what we need to do has to be built into our training and given time, thought, and preparation in order to give you the final product. It is also a good time to mention being careful about social media. There's a tendency to share everything immediately, which of course is the intention of social media, but it's not that good for patient confidentiality. It's also not that good if somebody's boasted online about doing something for the first time. Also not good if they put in some details of when it was and what the procedure was, because that patient is then potentially compromised. But just think about it. When the patient has a major complication 5 days later, how are you going to feel about that post? So just be very judicious. The best way for sharing in social media is definitely either through the educational channels with proper patient consent given beforehand, or immediately more for information, research, sharing of clinical type data, but not really for individual patient contact, a personal view. And that brings me to the very final point that I'd like to make today, and that is that none of this will happen unless we all focus on equality, diversity, and inclusivity. We have to think about other people, other trainers, other trainees, other patients, and think about being in their shoes and try and think some more about how to get that balance right, to get each of those aspects right, because this underpins pretty much us getting everything else right in the long term. And on that rather somber note, I'd like to say thank you very much for the amazing invitation to Barcelona. I've really enjoyed the time I've being spent here. We had a wonderful dinner with the trainees last night, and I was very grateful to you all for your hospitality. And a warm hello from Cambridge. Thank you.
Thank you so much, Dr. Fernhead, for such a fantastic and inspiring talk. We have to think about how we are providing now our teaching to our trainees and what can we do to improve it. Thank you so much. Pues ahora continuaremos con la entrega de los premios. Y entregaremos en primer lugar el premio al mejor residente del servicio de cirugía general. Como ya mencioné al principio, este premio es el resultado de la evaluación de los residentes a lo largo de todo el curso académico, también el resultado del examen que hacen al final del año. El premio lo entregará la doctora Patricia Sánchez, que es una de las tutoras, y este premio por primera vez es un premio exequo para nuestras dos residentes mayores que han finalizado este año, para la doctora Clara Téllez y para la doctora Annabel Martínez. Enhorabuena. Continuamos con el premio al mejor docente del Servicio de Cirugía General durante el curso académico 2021-2022, Premio Ignasi Poves. Este es el tercer año que lo entregamos, que también, como mencioné anteriormente, en este caso es un premio que tiene especial valor porque lo otorgan los propios residentes del Servicio de Cirugía, con votación para todos los miembros, en el cual participan en esta votación, pues entran como candidatos todos los miembros del servicio. El premio también, como en estos años, lo entregará Ana Coma, y el Premio Ignasi Poves de este año ha sido concedido a la doctora Leyre Lorente. Y finalmente entregaremos el 23º premio Lino Torre. Y leeré el acta de la resolución de este 23º premio Lino Torre. Reunidos en Barcelona, los asistentes del comité evaluador fueron el doctor Manuel Pera, la doctora Marta Pascual y yo mismo, se excusó la doctora Pilar Torre. Y reunidos en Barcelona el 30 de mayo de 2022, los miembros que acabo de citar se constituyen en tribunal, del cual es presidente yo mismo, doctor Miguel Pera, y secretaria la doctora Marta Pascual. Manifiestan, en primer lugar, quieren dejar constancia de la gran calidad de los trabajos presentados en esta convocatoria y, después de haberlos valorado y calificado de forma individual, resuelven conceder por unanimidad el 23º premio Lino Torre al trabajo titulado The Cost of Postoperative Complications and Economic Validation of the Comprehensive Complication Index, a Prospective Study, publicado en la revista Annals of Surgery en enero del 2021, del cual es firmante el doctor Roberto de la Plaza, en representación de un equipo formado por miembros del Servicio de Cirugía General y Digestiva del Hospital de Guadalajara. Las razones principales de esta decisión se centran en las implicaciones que tiene la validación económica de un método que permite realizar un análisis exhaustivo de las complicaciones postoperatorias y sus costes reales en los diferentes servicios. Ello puede ayudar a proponer medidas para mejorar los resultados clínicos y optimizar la asignación de los recursos financieros. El exhaustivo análisis prospectivo y la publicación en una de las mejores revistas internacionales de cirugía han sido factores determinantes en la elección frente a otros trabajos presentados en la presente convocatoria, todos ellos de una gran calidad. Enhorabuena. Y ahora el doctor Roberto de la Plaza hará una breve presentación sobre el trabajo que ha sido premiado.
Buenos días. En primer lugar, quiero dar las gracias al Hospital del Mar, al Servicio de Cirugía, a la familia del doctor Lino Torre y por concedernos este premio tan prestigioso. El trabajo que voy a presentar es un trabajo difícil, no solamente difícil de elaborar, sino difícil de contar. El trabajo cuenta con 16 tablas y la verdad es que se puede perder uno entre costes. Es muy difícil, pero voy a intentar hacer una aproximación fundamentalmente a la metodología que se hizo y, bueno, y a los resultados con las significancias. Quiero agradecer fundamentalmente, como he dicho, al Tribunal del Premio, al Hospital del Mar, al Servicio de Cirugía, al Servicio de Cirugía del Hospital Universitario de Guadalajara, al Servicio de Admisión y Documentación Clínica y Gestión Económica, fundamentalmente por su labor en la facilitación de estos datos. A Sagrario Casas y Blanca Grupelli, a José Manuel Rami Ángel, es coautor del artículo y además por todo su apoyo, todo el cariño que siempre me ha dado y el afecto. A mi madre, por todo lo que me ha dado y todo lo que siempre me dará, y aunque no puedo entender ni recordar lo que supone este nombramiento. a mis amigos, fundamentalmente todos sabéis que hay que dedicar mucho tiempo a este trabajo, no solamente a la profesión, sino a cualquier trabajo de investigación, y esto se lo robamos a los seres queridos. Y esto por eso digo que a mis amigos que he robado tanto tiempo en compartir amor, vivencias y emociones, por su cariño, por su generosidad, por la comprensión y solidaridad que me han demostrado y por estar siempre presentes. El origen de este trabajo es el trabajo fin de máster de Administración y Dirección de Servicios Sanitarios, el MAS 27, que está hecho en colaboración de la Universidad Pompeu Fabra y la Fundación Gaspar Casal. La clasificación de Claviendino es un sistema de clasificación que es muy intuitivo y fácil de utilizar. Es el más empleado en el mundo. Se publicó en el año 2004 y hoy tenía 19.627 citas del artículo original. La clasificación, no podemos obviar esta clasificación hoy día. Su facilidad, su universalidad nos puede servir para comparar, desde luego, hospitales, servicios y fundamentalmente resultados. Optar por clasificaciones que determinan una a una las complicaciones no nos lleva a ningún sitio. Aunque es muy intuitiva, la clasificación tiene muchos también problemas en clasificar pacientes, escenarios muy difíciles y requiere una formación. ¿Qué ocurre? Que complicación es cualquier cosa que ocurre anormal en el postoperatorio, pero anormal, por ejemplo, es también unas náuseas en una cirugía esofágica. Esto normalmente nadie lo pone en complicaciones. El admitir esta clasificación es integrar todas estas complicaciones. ¿Por qué? Porque es lo que verdaderamente hace a que los observadores apliquen la misma metodología siempre. No hay excepciones ni las debe haber. El problema que tenía la clasificación de Claviendino para clasificar es excepcional, pero el problema es que los posoperatorios son iguales todos en cuanto tenga una o múltiples complicaciones. Se rigen por la de mayor entidad. Esto no puede ser. El mismo grupo de Clavien, en el año 2013, publicó el Comprehensive Complication Index, que lo que pretende es aunar en una cifra de 0 a 100, resumir todo el posoperatorio. Esto vale para clasificar y fundamentalmente vale para comparar. La clasificación de Claviendino y el Comprehensive Complication Index por primera vez fueron validados a nivel mundial a 90 días por un trabajo que hicimos en el Servicio de Cirugía General. También fue Annals of Surgery y verdaderamente la gran importancia de este trabajo es que hoy hablar de complicaciones a 30 días es obsoleto. Hoy hay que hablar a 90 días. Clavien, solamente podíamos utilizar la clasificación de A30. Evidentemente, este fue un trabajo en un servicio con todos los pacientes, pero bueno, yo creo que es el inicio para poder ampliar esta clasificación a los 90 días. Entonces, la CEC representó una mejora con los resultados clínicos y superó, el CCI superó claramente a la CEC en pacientes con 2 o más complicaciones. Os podemos decir que en nuestra serie, en la de Clavien, el porcentaje de pacientes con complicaciones que tenían más de una era del 51% y la de Clavien del 47%. Presentamos una evaluación económica de las complicaciones posoperatorias desde la perspectiva del hospital. Tenemos muchas maneras de mirar la economía, los costes. Aquí fuimos muy, por una cuestión también de costes, de tiempo, fuimos muy restringidos justo al dinero empleado por el hospital. O sea que es una perspectiva económica obviamente limitada, pero está descrita y como tal está considerada en los sesgos. Y utilizamos todos los procedimientos quirúrgicos llevados durante un año. Evidentemente quitamos algunos, ahora os lo comentaré, y utilizamos con los datos, los costes con los datos de la CDC y el CCI. Se trata de un estudio prospectivo observacional de corte. El objetivo principal era validar desde el punto de vista económico la CDC y el CCI, utilizando su relación con los costes de diferentes perspectivas. Por un lado, los costes de la serie global de todos los pacientes, de cirugías concretas, de cirugías clasificadas según su complejidad y según el número de complicaciones y también relacionarlo con la prolongación de la estancia. ¿Por qué hicimos esto? Fundamentalmente porque queríamos tener varias perspectivas y ver si ambos índices, la clasificación de Clavien y el CCI, se relacionaban en todos estos aspectos. Los objetivos secundarios los veis: medir los costes postoperatorios, analizar la asociación entre el coste del quirófano inicial, que evidentemente no entró en los costes, pero sí ver si esto tenía alguna relación con lo que luego pasaría con el tema de las complicaciones, y determinar el impacto en el coste global que supondría aumentar una unidad, el grado de Clavien, o aumentar una unidad sobre 100 el CCI. Se incluyeron todos los pacientes que fueron intervenidos en el área sanitaria, que tenemos un área sanitaria en aquel momento de 254.000 habitantes, durante el periodo de un año. Se excluyó la cirugía menor ambulatoria y aquellos escenarios complejos, no está escrito en la diapositiva, en la que podía haber sesgos en la determinación de la morbilidad. Imaginaos pacientes que venían de otros servicios, que habían sido intervenidos previamente, etcétera, etcétera. El seguimiento se incluyó en todas las complicaciones durante la estancia hospitalaria y hasta los 90 días o después, si el paciente permanecía ingresado por el ingreso inicial o por un reingreso. Lo digo, lo hablamos, la clasificación de Clavien. Complicación era cualquier evento que ocurre durante el posoperatorio, evento negativo, aunque estuviera solo remotamente relacionados con la cirugía. Tened en cuenta que Clavien, en su artículo del 2004, dice que un paciente operado de una tiroidectomía que hace una hernia crural en el posoperatorio se debe considerar una complicación, aunque a nosotros nos parezca. Insisto, ¿cuál es la gran ventaja de esto? La gran ventaja es que se anula la subjetividad al máximo. Se formó a los facultativos del servicio, se dio documentación de apoyo, se hizo un formulario específico para complicaciones en la historia clínica electrónica y a la hora de la revisión se revisaron todas y cada una de las notas de los comentarios médicos y de enfermería de todos los pacientes. Tener en cuenta que en un trabajo posterior el analizar los comentarios de enfermería aumenta en un 11% las complicaciones. Utilizamos la fórmula, en lugar de la fórmula que hay en online, utilizamos la fórmula descrita por los autores porque, bueno, era, desde el punto de vista científico, era más adecuada. Vamos a ver, la serie es muy compleja, son 1.850 pacientes intervenidos de cirugía más mayor, menor, etcétera, etcétera. Utilizamos dos parámetros fundamentales. Uno fue el Operative Severity Score, que graduó las complicaciones en 4. Las cirugías en 4 grados, y otros utilizamos cirugías muy prevalentes en servicio con esas características: apendicectomía, colectomías, hernioplastias con ingreso y colecistectomía laparoscópica no urgente. En cuanto a prolongación de estancia posoperatoria, fue cuando el tiempo de ingreso a un paciente fue mayor al percentil 75 de tiempo de cada uno de los grupos de los procedimientos considerados. Los cálculos de coste, esto fue muy difícil. ¿Por qué? Fundamentalmente porque los hospitales no tienen un coste completamente analizado por paciente en cada una de sus facetas, es decir, el coste en farmacia, el coste en pruebas radiológicas, el coste en hostelería, etcétera, etcétera, ¿no? Nosotros, con los costes que nos dieron, que fueron los costes de quirófano por minuto de utilización igual para todos los quirófanos, es decir, cirugía compleja o no. Exploración radiológica, sí, teníamos el coste de las exploraciones y los costes medios producidos tanto en la hospitalización como en el servicio de urgencias. Se calculó en cada paciente el coste de quirófano inicial, todos los costes posoperatorios, los costes de las reoperaciones, los costes de los reingresos, incluido el tiempo en el servicio de urgencias o en el ingreso en otro servicio, y se excluyeron, evidentemente, todos los costes preoperatorios o de pruebas de otros procedimientos que, imaginaos, el tema quimioterapia y exploraciones oncológicas que no tenían que ver con el procedimiento inicial. Dado que el estudio abarcaba 2 años, utilizamos, para evitar los sesgos, utilizamos el precio del año 16. Se quitaron los pacientes fallecidos. ¿Por qué? Pues os lo podéis imaginar, porque un coste, el paciente fallecido puede fallecer en quirófano y el coste es justo el del quirófano, teniendo una morbilidad de 100. El non-survivor bias. Sesgos, muy importante. Estos sesgos los teníamos antes de empezar el trabajo e intentamos suavizarlos al máximo posible. La evaluación económica se limitaba a la perspectiva del hospital. No se consideró asistencia sanitaria aquella que no pasó por el hospital. No recoge los reingresos en otro centro hospitalario. Éramos o somos el único hospital del sistema público de salud, con lo cual este sesgo parecía que era poco. Se incluyeron muchas, lo he comentado antes, patologías de diferente complejidad. ¿Cómo intentar hacerlo más homogénea con la Operative Severity Score? El problema es que todavía siguen siendo muy homogéneas y nos daba miedo que el validar el CCI estuviera hecho sobre una base con mucho sesgo. Por eso utilizamos otros 4 procedimientos que os habéis visto. Y este sesgo a mí me gusta mucho porque este sesgo a mí me sorprende cuando en los artículos a nivel mundial, en revistas de impacto, los autores dicen que no tienen conflicto de intereses. ¿Vosotros pensáis que no es conflicto de intereses el que esté analizando sus propios resultados? Y esto no se sabe la influencia que puede tener en el resultado de la morbilidad. ¿De acuerdo? Este es un sesgo muy importante que no tenemos controlado. Y bueno, y que los datos de los costes económicos de cada paciente se distribuyeron por igual en cada día de estancia en todos los hospitales. Es decir, la farmacia, las analíticas, las prótesis y la hostelería fue igual para todos. Y que el análisis efectivamente fue realizado en un único centro. 1.850 pacientes, 2.111 intervenciones quirúrgicas, se excluyeron 96 pacientes y, fundamental, no se perdió ningún paciente para el estudio. Presentaron complicaciones el 27% y falleció el 2,3%. Vamos a hablar de la relación ahora fundamentalmente de la CFE y el CCI con el coste global de la serie. Tuvieron una correlación muy fuerte en la serie total y además nos dimos cuenta de que a medida que aumentaba el ACC, proporcionalmente aumentaba más el coste. En cuanto a los grupos homogéneos de la cirugía, igual hubo una diferencia significativa con el coste global, igual que con la CCI. Y en los grupos del Operative Severity Score, más de lo mismo. La diferencia fue palpable. Voy un poco deprisa porque quiero poneros alguna tabla para hacerla un poquito más evidente. Se correlacionan de manera moderada fuerte en todos los grupos. Os resumo, todos los grupos y todas las intervenciones, todo tuvo una correlación positiva y, exceptuando, ahora lo veis, 2-3 complicaciones, el resto, la correlación fue moderada a fuerte. Aquí es donde tenemos el defecto, que no sabemos muy bien por qué. Había solo una correlación directa, estadísticamente significativa, desde luego, en los pacientes que tenían 2 o 3 complicaciones y moderada fuerte en el resto. La prolongación de la estancia hospitalaria, hubo relación de la CEC moderada, fuerte en este caso, y el CCI con la prolongación de la estancia hospitalaria, tanto si la tenían como si no. En el caso de que la tuvieran, veis que la correlación fue de 0,83, fue bastante amplia. El coste del quirófano inicial, sé que esto no tiene que ver con los costes operatorios, pero sí que posoperatorios, pero sí que queríamos tener una idea de cómo se relaciona, si había alguna relación. Parece obvio, pero bueno, también se demostró que a medida que aumentaba el coste del quirófano inicial, aumentaban las complicaciones en grado de la CEC y en el CCI. Aquí en esta pantalla, pues ahí vais a ver un poco las correlaciones. Tened en cuenta que la correlación de Spearman, vimos que se utilizó lo que hoy día está publicado a nivel mundial, 0,10 a 0,29 era una correlación pequeña, moderada 0,30 a 0,49 y 0,50 para arriba era una gran correlación. Ahí os dais cuenta de que los costes de la correlación 0,44, 0,45, el CCI tuvo una correlación mayor que la clasificación de Clavien. Veis por los grupos, igual, las correlaciones moderada a fuerte en todos, sobre todo en las colectomías y en la cirugía mayor y sobre todo la mayor plus. La prolongación de la estancia, como os he comentado, se asocia hasta un 0,83, correlación muy fuerte. En el análisis multivariante demostraron que la CC y el CCI, la edad y el tiempo de cirugía estaban relacionados con el coste global. A mayor CC y CCI y tiempo de cirugía, mayor coste global. Y por el contrario, los pacientes más ancianos, no lo podemos explicar, tuvieron un coste inferior. Se relacionó en el análisis multivariante negativamente con la CC y CCI y con el coste global. Y el ASA solamente se relacionó en la clasificación de Clavien, en el modelo multivariante. Bueno, ahí lo tenéis. Los resultados. Bueno, aquí esto es interesante, lo podemos ver cómo se relaciona, evidentemente, cada aumento en un grado de Clavien o cada aumento en una unidad del CCI aumenta, obviamente, el coste. Y esto sucede en todos los procedimientos. Lo vamos a ver en la tabla. Bueno, pues veis que aumento de un punto en el CCI en la serie global, 243 euros. Un grado de la CEC, 3.000 euros. Cuando hablamos de la apendicectomía, un grado de Clavien, es decir, que el paciente ha tenido vómitos, podría ser, aumenta en 975 euros. En la colectomía, un grado de Clavien en 3.600 euros. En la hernioplastia, 681. Y la colecistectomía, 1.138 euros. Esto porque el paciente vomite, por ejemplo. En cuanto al Operative Severity Score, vemos pues un poco lo mismo, ¿no? A medida que los costes fueron superiores, el aumento de una unidad en función de la complejidad de la cirugía, es obvio. 1.000 euros, 2.283, 3.200 y 5.130 euros en la mayor plus. La mayor plus es la cirugía, las amputaciones abdominoperineales, las resecciones hepáticas mayores, las esofagectomías. Bueno, voy a concluir. La CC y el CCI se correlacionan de manera moderada a fuerte con el coste posoperatorio global en todos los grupos del Operative Severity Score, en las cirugías homogéneas, con la prolongación de la estancia posoperatoria y el coste del quirófano inicial. Se demostró una tendencia creciente en el coste posoperatorio global a medida que aumentaba el grado de la CEC. Y en el análisis multivariante, la CEC, el CC y la edad y el tiempo que duró la cirugía se relacionaron con el coste posoperatorio global. El CCI en nuestro medio se relaciona con el coste global desde las diferentes perspectivas considerado, lo que potencia, obviamente, su validez clínica. Me vais a permitir que tenga un sesgo muy importante y es que me gustaría deciros que en el Congreso Nacional vamos a hacer un taller de un día de decenas de pacientes y con más de 15 instructores sobre la clasificación de Clavien y el CCI, cómo hacer la metodología y cómo hacer los registros. Muchas gracias.
Muchas gracias, doctor de la Plaza. Enhorabuena una vez más por este trabajo, realmente un análisis, como he dicho antes, muy exhaustivo de las complicaciones y de las implicaciones económicas que tienen. Somos conscientes de las implicaciones que las complicaciones tienen sobre nuestros pacientes, también sobre los propios cirujanos, pero ahora ya también podemos ver incluso complicaciones menores, esas implicaciones económicas tan importantes que tienen y que de alguna forma pues también la disminución de esta morbilidad puede permitir asignar recursos financieros a otros objetivos. Una vez más, enhorabuena. Y ahora sí que vamos a dar por finalizado este 24º memorial Lino Torre. Agradecerles a todos su presencia. Es un placer volver a verles otra vez y reunirnos para celebrar este memorial, en memoria del doctor Lino Torre y la entrega anual de premios. Y les emplazo a reunirnos una vez más en mayo del 2023, en el que será ya el 25º memorial. Muchas gracias.